Hello, I'm Betty Casey, editor of Tulsa Kids Magazine, and the Children's Hospital at St. Francis and Tulsa Kids Magazine have teamed up to bring parents a series of videos and articles about important children's health and wellness topics. You can find them under the heading PJ's Corner in Tulsa Kids Magazine, along with a complete written and video interview on Tulsa Kids website. Today, we're talking to Dr. Scott Moseman about pediatric eating disorders. Dr. Moseman is MD CEDS. He serves as the medical director of Laureate Psychiatric Clinic and Hospital's Eating Disorders Department and is attending physician for the adolescent program. He is a board certified child and adolescent psychiatrist. Welcome, Dr. Moseman.
Thank you. Thank you so much for having me.
Great to see you. Okay, so we're going to talk about pediatric eating disorders. And usually when I hear the words eating disorders, I think of teenage girls with anorexia or bulimia. So
Sure.
Can you define pediatric eating disorders for us and then talk about some of the most common types?
Sure. I think, probably in the last, 30 to 40 years, the thing that's changed about mental health is that we see things from a developmental spectrum. Halfway through the 20th century, they didn't believe that if your child or a young one had an issue, they thought that it was all due to parenting, it was all due to how they were raised or what they were did or exposures that they had. And so I think us understanding that kids are sort of born with a certain type of wiring, that can be predisposed to anxiety issues and depressive issues, ADHD, other kinds of things, that we kind of see things now across the developmental spectrum that for some people continue into adulthood or not. Eating disorders are really stress and anxiety disorders, in which I think the individual chooses to sort of utilize the manipulation of food to try to take care of themselves and to try to feel in more control. Certainly anorexia nervosa, which usually strikes, still a pediatric disorder, strikes usually around menarche for females, sometimes in the early teens for males, and developmentally sort of works over time. Bulimia, where there's, binge eating and some sort of undoing of that binge eating, or even a binge eating disorder, are all things that can be a result and cause eating issues. And those things certainly can happen in latency age kiddos or kiddos probably younger than the age of 12 or 13. They certainly are less common, especially in females. I think the hormones that come along with puberty do make depression, anxiety, and eating issues more common. But we can see eating issues in kids. I think as we're looking and talking about pediatric obesity, recognizing that there can be some behavioral, and binge implications in some of those patients. The other thing is there's another illness called avoidant restrictive food intake disorder, or ARFID. This has been recognized for a while, but there's probably a subsection of kids, especially young kids, who are basically extreme picky eaters, right? So I was somewhat of a picky eater growing up. I think it can run, like, our sensitivities are different when we're younger. And I think any of us, I have multiple kids at home, some of which are more adventurous or less adventurous eaters. ARFID is really a case, again, usually probably together with sensory issues and some stress or anxiety issues, where there's a huge limitation of foods. Like, they can only eat 5, 6, 7 foods. Sometimes those foods don't always even have the full nutrients that the patient needs. And as a result, they can have medical or other complications with that. Some of those patients will develop other eating disorders as they get older. Some patients, as they get older and their sensitivities decrease, will sort of grow out of those illnesses. But there are illnesses that can need treatment, and ARFID is probably more commonly before those teenage years, where most of the other eating disorders are more common after the teenage years.
Okay. You talked about, you touched on anxiety, and is that a cause, or maybe a person who is born with heightened levels of anxiety?
Sure.
So what causes eating disorders, and how common are they? Are eating disorders a symptom of something else, or is that the illness itself?
It is, that is, that is the question that's on the mind of science, I think, a lot, right? Which is the types of questions, a lot of times in mental health or mental illness, we do describe things phenomenologically, right? If you're sad, get depressed, if you're anxious, and recognizing that there's spectrums of illnesses and then different ways I think our brain responds to those. So, I kind of like to look at a broader way in which I view neurologically how my patients present, which is if you have brain stress resiliency issues. In other words, if your brain sort of runs into a situation in which it doesn't go exactly how you want, how do you respond, right? And I think we can think of people in our lives who are more anxious would tend to respond by either shutting down or getting nervous or trying to manipulate and fix things, or some people that are very laid back that kind of take things as they come and it's kind of easygoing. I do think some of these are hardwired, into us, and that they can happen when we're young. So I think in eating disorders, I think they do try to, they affect people that have brain stress resiliency issues. I work with Dr. Sahib Khalsa at the Laureate Institute for Brain Research. And right now we're actually doing research to look at both with GI systems, with brain systems, especially the insula, how does the brain and body interact differently in somebody that gets an eating disorder than some that don't, hopefully looking at what might be a risk. We know that kiddos that grow up with self-esteem issues, kiddos that grow up with anxiety, especially if they're avoidant in their anxiety, kids that grow up that have somatic illness, headaches, stomach aches, especially we see a lot of GI-oriented anxious issues that are more likely to develop, and especially like anorexia. So, I think those are the questions that science are still trying to get to, which is, fortunately, unfortunately, let's say if I have a teenage daughter myself who's in high school, most girls by the time they've entered high school have been on a diet. Most girls in the last 30 days of high school have tried to restrict their eating. Rates of anorexia are still about 1% of females, right? Eating disorders in general maybe affect 3 to 5% of people. So there's probably something underlying which, when they manipulate their eating, provides some sort of relief. Unfortunately, that relief over time can become a problem and doesn't allow them to support themselves.
Okay, yeah, that makes sense. So that was part of my question: is how common is it?
Yep.
Girls can suffer from it, but also males.
Yeah, so I think what we're seeing over time is just like, especially when you take 13 and up, when you're starting to take hormones and things into account, young women and women suffer both depression and anxiety at a higher rate than men, probably related to sort of hormone and hormone related issues, probably hormones that also make women good mothers and those kinds of things later on if they decide to have children. But so almost 30% lifetime incidence of depression and anxiety for females, less for males. However, we're certainly seeing more pressure being put on males and males' bodies. Also, just more males coming out of the woodwork, talking about symptoms, that this isn't just an illness that can affect females. And as a result, I think we're seeing, though it's still more common in females, we're seeing it happen more commonly in males. What is probably interesting is something like ARFID, there's less sort of sexual differences or distributions, probably equally likely to happen in both. And sometimes, because ARFID can happen more commonly in people who maybe are autism spectrum, maybe even some leanings to males more often as they're younger.
Looking at those kids, those younger children who have that kind of extreme food avoidance, are they possibly more likely to, in adolescence, to have an eating disorder such as anorexia nervosa or bulimia?
It's a good question. I would say that there is a subset of the population, that if you add, a little bit of body image issues or other kinds of things, that things can sort of morph into an anorexia and those kinds of things. I think it happens. I would say it's more common that they generally, hopefully, either through time or exposures, will sort of develop out of it, or at least where it's less interfering. Like they still might not have the wide compendium of foods, but it's enough where they can kind of exist and get their needs met. So, unfortunately, I don't think we have good studies that show exactly, you have 100 kids with ARFID, what do they look like in 10 years? So that would be a good study. but I think that a fair amount of them grow out unless other things come along for the ride. So they've actually chosen to manipulate food, so it might be more likely as they become teens that they'll continue to do so in a different way.
Mm-hmm. If you have a child who, a lot of kids go through phases where they don't want to eat certain foods. What's the difference between a kid who's a picky eater and a child who has a problem? How do parents know?
Yeah, I mean, it's kind of like, if you just take anxiety in general, right? Anxiety is her, right? Have anxiety exist in us as a species for a reason because it's adaptive and it helps us survive, right? We know that anxiety is tied to intelligence. We know anxiety is tied to empathy, right? And those are things that we tend to want our children to have, right, as they move forward. I think the same thing sort of happens around eating is that people are born. There's even some genetic reasons why people can be, pickier eaters. There's actually one gene that can affect how certain vegetables might taste more
Mm-hmm.
bitter or less bitter. And when you're a kid, also everything, all sensitivities are turned up. So for all mental illnesses, for me, it really becomes a function, right? When a kid comes in my office, no matter what they're presenting with, it's like, well, a kid should be able to eat, sleep, go to school, have some friends, and do the sort of normal developmental kid stuff. And if they're presenting with a problem that doesn't, I don't want to eat, so I don't go to lunch and I don't hang out with friends and I'm not meeting my nutritional needs, I'm having some deficiencies or I'm not meeting my growth curve because I can't find enough nutritious foods to eat, or because of the anxiety that runs with my eating, I can't go to school or I refuse to leave home or I'm having panic attacks. Those would be things that where I'm like, okay, now this is getting in the way of normal function. For most kids, picky eating, I have 2 out of my 3 kids are picky eaters at home. Now I'm an eating disorder doc, I eat fine. Some of that can be due to other sensitivities and they will tend to outgrow them. You're just trying to, can we meet needs and, can everybody pick the same restaurant? But over time, if these kids I see that really struggle, they're eating a certain type of chicken nuggets only from this restaurant and these 3 other things, parents are going out of their way and some of them will need feeding tubes because to meet nutritional needs or medical needs. And treatment can be hard and frustrating because it's really about exposing slowly over time and trying to expand things. Hopefully at the same time where developmentally they're able to step back and see the bigger picture as well.
Well, you mentioned exposure for those kids. What are the treatments for adolescent eating disorders? So more anorexia, bulimia. How do you treat that?
Right. So, what we're lucky, I think, at Laureate is that we're lucky. We have one of the longest, oldest running treatment programs in the country, also a not-for-profit treatment program. And we've been running since the late 80s, and we have inpatient services available. We have outpatient services available. And I think like any other illness, the goal is to treat it with the least amount of intervention that you can, right? All eating disorders do not come in the same severity as well, too. I'm going to be a little bit artificial in dividing them up, but if I look at anorexia or restricting illness, you do have to fix making sure that their brain and body's nourished, right? When their brain and body's nourished, meds don't work as well, therapies don't work as well, and the brain just has a harder time thinking they're bad at it. So almost all studies, when you have some of this other shows that getting their nutrition back and exposing them to more foods is helpful. And then you treat the underlying anxiety. What other things do you need to do to be able so that when they get anxious, they choose not to manipulate their food? In bulimia or binge eating, I think it tends to be more of an impulse. They feel anxious as well, but then their goal tends to be more, how do I make my brain feel better as soon as possible, right? And so then it becomes more treating their anxiety and getting them to sort of put off what other behaviors they have, make sure they don't get other behaviors, impulsive behaviors like drugs or alcohol. The key with both of them is you're trying to treat the anxiety while maintaining their nutrition and not doing things which actually make them feel worse over time. And that can be as much as outpatient dietitian and parental support all the way to full bore 24-hour day care for people with extreme malnutrition, need 6 moderate meals a day, therapy for sometimes weeks or months at a time.
So they need to be physically healthy to help their brains as well. So what or have enough nutrition that you can treat them.
Yeah.
So what's the long-term effectiveness of treating eating disorders? Is this something that people will have throughout their lives that they'll have to deal with, or is there like a cure and you're done? Or
Yeah, sometimes because eating disorders aren't common, it's easier to sort of, though they're not the same, make some comparisons to other types of illnesses. Again, just like there's different severities, I think people have different results from treatment. In anorexia nervosa, for instance, still over the longitude of the illness kills between 8 and 10% of people that get it, right? So you're certain types of acute leukemia, your daughter might have a better chance of surviving than if she's diagnosed with anorexia. So it can be a very serious illness over time. That being said, about 90% of people will find some sort of recovery. I've seen that take as little as several months and as much as several years. So the two examples I would give in medicine, I would say it can be like asthma, right? So if you're having attacks, you might be younger and your body adapts and grows. And as you get older, maybe only if you're at altitude or whatever, you don't hardly ever have an attack again and don't even have asthma anymore. Sometimes you might find that you need sort of chronic therapy over time. Alcohol and drugs will be the other thing, right? So sometimes people will say, I got sober, and in European countries they do controlled drinking. Not everybody has to completely be sober from that. Some other people will say, no, every day I wake up thirsty and I have to remind myself why I need to stay sober today. And if I go back and have one drink, I'm going to fall over the edge. I think that's what's interesting about humans and human brains is they act differently. I've been here 19 years now. It's family week this week, so I ran over and I just had a patient actually 7.5 years ago, and she's there with her husband and her 2-year-old baby girl, and basically saying, I don't think about eating, doing my life and doing things, and didn't even think about coming other than we asked her to come back and be a speaker for our patients that are in the hospital right now. So that happens a lot. I think treatment is much better than it was 20 years ago. We do a lot better job about not blaming families, and in fact using families as a structure and support to make sure somebody can get their food in and the emotional support they need. We know a lot more about the medicines and how they work over time. So I think we do a better job, but it's still an illness which has a lot of morbidity and mortality, and that needs prompt and complete treatment.
okay. And getting into treatment, I guess my last question is, what should parents be looking for? What signs and symptoms should they be looking for? And then if they are concerned, what should they do?
Right. Like all things, being a parent myself, I think just taking active part in your kids' lives and what's happening, as they become teenagers, they don't always want you to, but I think it's still important to be around and available. What happens in eating disorders is certainly seeing changes in dress, changes in weight, making sure you're making your pediatrician appointments, changes in their ability to eat. Are they eating with you? Are they eating privately? Do you notice changes in their skin tone and their weight, in either direction, right? The other mistake we make is thinking only about weight loss when it comes to eating disorders, and sometimes things like bulimia, things like binge eating, your weight can stay the same, possibly even go up a tiny bit. So it's really being aware of eating attitudes and behaviors. I, I have kids in sports and other kinds of things, so family meals are hard. I think the loss of the family meal is really a loss for us as a society, right? To sit down together, ask about your day, highs and lows. Are people eating? Are they doing okay? Do they have friends? What's going on? I think it gets so busy that we forget to pay attention to the important things. And then in the first place to start, it can be with your pediatrician, right? They see changes. most kids track pretty, and we're a healthy at any size program, so we don't believe people should be a certain weight, but most of us will be a certain height and weight throughout our lives if we're eating a reasonable balanced diet. And if you sort of fall off of that or those change, that can be a warning sign. And just any change in sort of functioning as far as how they eat, whether they're willing to eat, lots of talk about their body, the way they look, and being unsure about that. Um, my sister's a pediatrician within the St. Francis Health System. She sends me patients, and sometimes patients are just thin. I was growing up, and sometimes there's not a reason. But I think sometimes we get so tied up in obesity and other issues that we forget any changes of eating, falling off the growth curve on the lower side. Somebody who had healthily generally run higher, but is now sort of average or low, checking in to see how they're eating. I think being aware of those things can be important. And then, we have a full compendium of resources here at Laureate. There's several excellent people in the community. That's what's kind of lucky about having a treatment center, is that like Tulsa really does have a lot of professionals who are very adept at treating eating disorders.
Okay, that's great advice. And just as a parent, checking in, like those family dinners, if it can't be a family dinner, just having an awareness and checking in with any changes in your kid that are big or small, but over time, making sure that
teenagers don't want to sit down and have a face-to-face chat and do stuff. But if you're busy eating or you're busy driving to a practice when they don't have to look you in the face,
yeah.
and let them talk about what they want to talk about, even if it seems disinteresting to you, because it does open up a line of communication and how things act, who they're hanging with, what their friends are, changes in those kinds of things, changes in grades, changes in what they want to participate in. They can be all signs of depression, anxiety in general, of which sometimes eating can certainly be involved.
Okay, I said that was my last question. It's not.
No, go for
it. What if you have, how do you approach that conversation if you do have concerns about your child? Do you say, I noticed you're gaining weight? Oh, I noticed you're losing weight. Is that bad? What do you say as a parent?
The truth is, there can be natural changes in those kinds of things. I think, especially if you're talking about teenagers, right? The normal response will be, if the normal response is annoyance and you're an idiot, and that's sort of a teenager being a teenager. If the response tends to be more, nothing's wrong, I don't know what you're talking about, or how, sometimes it is in the reaction how it works. Sometimes it can just be saying like, I noticed that you're not eating with the family anymore. A lot of times, a lot of the patients I see, friends, sometimes, we can say what we want about Gen Z, but they're more aware of their mental health than we were growing up. And so I get a lot of cases where friends are noticing that their friends not eating at school, and they're the ones that are informing parents like, hey, Frank or Susie has stopped eating with us, or they're on some calorie counting app on their phone, and I have concerns about them. I think it's taken them seriously enough to investigate. I don't have problems. People come to me sometimes, the overly anxious parents. I don't have a problem saying, nope, this looks normal, but here's the signs to watch for. If this happens, go ahead. That probably happens less often than the patients I see from California who are like, well, I knew our weight was going down a year ago, but I didn't think it was a big deal. And now we're traveling halfway across the country because, our heart rate's 45 and, there's not good treatment around us. So we're having to travel to Tulsa, Oklahoma to get 3 months worth of care. So asking the question, never a convenient time, never convenient to talk about sex and friends and mental health and those kinds of things. And the teenagers might not even appreciate it at the time. I still think it's very necessary to do.
Okay. Is there anything else that you would like to tell parents? Any other advice or thoughts?
No, I think you did an excellent job. I certainly appreciate the interview.
Okay. Well, we appreciate you taking the time to talk with us today. I learned a lot, I know. I also want to thank the Children's Hospital at St. Francis for partnering with us on this. You can find this entire interview and more like it on our website at tulsakids.com and PJ's Corner in our magazine. So thank you, Dr. Moseman. It was
great.
nice.
Thank you very much. Have a great day.